Good afternoon. This is Dr. John Bennett, televising from Miami. We have another conference in the continuing conference of Pediatric Neurosurgery. Neurosurgical TV is collaborating with AIIMS Hospital and the Department of Neurosurgery with Deepak Gupta in New Delhi. Today we have a conference of Dr. Suhas Udayaku Moran and Dr. Pramod Subhash, who are going to talk about craniofacial dystosis syndrome sequencing treatment. And first we want to introduce the panel before we turn it over to the doctors to present. Hello, Deepak.
Hi, welcome Suhas and Subhash, and I'm really looking forward to your talk. You aptly justify the theme that craniofacial surgery should be done as a teamwork, and the very fact that both of you guys are together, I'm sure the concept of teamwork will be shown to the rest of the world. In fact, I have learned a lot of my craniosynostosis surgery from both of you guys, and so Pramod is also doing a lot of work on 3D print technology. So I really look forward to the talk by both of you. Thank you.
Very good. Dr. Srinivas, welcome back.
Yeah, thank you.
Could you please introduce yourself?
No, we had a farewell function for one of our staff who was retiring, so I had to go there.
Very good. Welcome back. And Simon?
Hello, everyone. Thank you for inviting me to this presentation. I'm a medical student in Japan and currently training in diagnostic radiology. Thank you very much.
Welcome, Simon. Okay, Suhas, it's all yours.
Okay, thank you. Thank you, Bennett, and thank you, Deepak. Thank you. Okay, let's start off with the topic immediately. Yeah.
Yeah.
So my talk will concentrate on managing the craniofacial dysostosis syndromes and how we sequence the treatment options. I'll be accompanied by my craniofacial and the maxillofacial surgeon, Dr. Pramod, who would highlight the complementary issues of these complex clinical problems. Okay, differently from the simple craniosynostosis, the management of which is well established, the management of complex synostosis has to be tailored to each child. There is a complex interaction between the skull, face, the CSF spaces, the vascular and the parenchymal structures. The cranial, ocular and the respiratory issues dictate the surgical sequence of management. Consequently, the neurosurgeon and the craniomaxillary surgeon work in tandem to resolve these issues. So the goals of management are to preserve the function by managing the raised ICP and to keep the quality of life by managing the aesthetics. So what do we look for? As I mentioned earlier, we look for the obvious signs of raised ICP. And these are the questions we try to answer. Is there a CSF diversion that's merited? Is a posterior distraction required? And if it is versus anterior, which one would you choose?
Excuse me, Suhas, the slide. Excuse me, Suhas, the slide is not moving.
Not moving?
No. You want to be on the first slide or the second?
I'm on the 8th slide.
Oh, okay. Well, the slides aren't moving.
Not moving?
No.
Okay.
There you go. There you go. Okay. There you go. Yeah, you got to click on. You got to click on manual. Yeah, that's good.
I'll just start off with the second slide, fourth slide, which is
that's fine.
Which is the content. Okay.
Okay.
So the goals of management are to preserve the function and to manage the raised ICP, and to preserve the quality of life by maintaining the aesthetics. So the obvious questions are, whether there are signs of raised ICP. If there are signs of raised ICP, how is it supposed to be managed? Do you need a CSF diversion? Do you need posterior distraction versus an anterior procedure? The other issues that are to be answered are whether there are aesthetic issues and to address the maxilla and other issues. So the various reasons for raised ICP are the craniocerebral disproportion, the obstructive sleep apnea, the hydrocephalus, and the venous outflow obstruction. So the raised ICP will depend on which sutures are involved and the syndromes. As you see in the slide, the sutures involved would change the proportion of raised ICP. You have a brachycephaly, which has about 31% of raised children with raised ICP, and you have the other end, you have the trigonocephaly, which has about 8%. Of course, this is the range. And then it depends on the syndrome which is involved. more complex the craniosynostosis, the more higher the chance of raised ICP. You have about 47% in a complex synostosis, whereas Cruzen's might have 63 and Appert's 45, and syndromes like Mumke's do not have possibility of raised ICP as per literature. So what do you look for? We look for the signs of raised ICP, the simple signs and symptoms of raised ICP, which all of us know. The occipital frontal circumference, which if it has plateaued, would suggest raised ICP, and possibility of raised ICP. The possibility of papilledema, which is about very specific for about 87% and sensitive for only 30%. In case the papilledema is not present, you might do optic nerve measurement and OCT, optical coherence tomography, whenever papilledema is not present and you still suspect high possibility of raised ICP. So in case these are not are all negative, and you still suspect high index of suspicion for raised ICP, you will look for you will do an invasive monitoring. So these are the protocols which we follow usually, and as we diagnose raised ICP, these are the questions we try to answer. If there are signs of raised ICP, what are we supposed to do? We would do sleep study. We would do a skull and brain imaging. And in the skull and brain imaging, we would look for ventriculomegaly, which has to be countered with the possibility of hydrocephalus and Chiari. Hydrocephalus occurs in about 4 to 10% in general craniosynostosis, with an extent of about 70% in Cruzen's and 90% in Appert's. Which is hydrocephalus by itself is rare and non-syndromic. The pathogenesis of hydrocephalus is crowding of the posterior fossa, the possibility of venous hypertension, and the ex vacuo collection along with the ventricular dilatation. Chiari, as we all know that it's referred to by the tonsillar herniation, and it's secondary to the small posterior fossa. The small posterior fossa leads to Chiari, and all this is secondary to the cephalocranial disproportion that happens in craniosynostosis. Chiari is observed in about 90% of patients with hydrocephalus, along with hydrocephalus in syndromic craniosynostosis. Chiari by itself is not sufficient for the onset of hydrocephalus. That means Chiari can exist independently without hydrocephalus. So Chiari cannot be considered as a simple result of chronic intracranial hypertension as induced by hydrocephalus. We diagnose this by MRI. We look for the amount of tonsillar herniation below the foramen magnum. That's standard. The extent of Chiari is about 70% in Cruzen's, higher in oxycephaly, and about 50% in Pfeiffer, and about 100% in Kleeblatt Shuttle. Plain metopic region can have about 30% of them. They are not present in the first 6 months. They develop later, and they are associated with premature closure of lambdoid, and they might be associated with genetic findings of exon 3 and exon 3C of FGFR3 2 in Cruzen's. So Chiari is probably related to early fusion of spheno-occipital, petroccipital, and occipital synchondrosis, which occur in Cruzen's, and which might be normal in Appert's. The anteroposterior growth is abnormal, and there's an early lambdoid closure. So it leads to jugular stenosis and a cranial base deformation, and which leads to cerebellar herniation, along with associated venous hypertension. And all this probably adds to give the effect of hydrocephalus. If hydrocephalus is present, the options are to do endoscopic third ventriculostomy, or a ventriculoperitoneal shunt, or posterior distraction. How do you choose between them? So this was a 4-month-old who presented with a full fontanelle. He came with a full fontanelle, and he had a classical obstructive kind of hydrocephalus with a tight posterior fossa. I went on to do endoscopic third ventriculostomy, and beyond that, he had a posterior distraction for his lambdoid synostosis. at 1 year, and beyond that he had a frontorbital advancement. So how do you choose between CSF diversion versus posterior decompression, and between ETV and shunt, how do you choose? So I'll try to illustrate with another case. This was a 3-month-old, a classical case of Ankle-Bixler, a very rare syndrome. He presented to us with severe failure to thrive. He had a disfigured head along with proptosis and limb contractures, classical for Ankle-Bixler. He had full fontanelle. He was in distress. He had intermittent breath holding. His fundus showed papilledema. There was increased nasofrontal angle and a hypoplastic midface and a flattened posterior head. This was his MRI, a tight posterior fossa with a Chiari and hydrocephalus. That was a CT scan, which showed the lambdoid synostosis. All the other sutures were open. These are the lambdoid synostosis, but at the same time, there exists multiple cranial lacunae secondary to the raised ICP and the syndrome. So what first? What would you start with first? Between CSF diversion, posterior distraction, and a frontorbital advancement, and between ETV or VP shunt. So as per literature and with our experience, we consider ETV should be the primary procedure in spite of possibility of high failure, because classically these are obstructive kind of hydrocephalus, although the mechanism is much complicated than as simple as that. So we chose to do ETV, endoscopic third ventriculostrophy, for this child. I mean, just some thoughts on these. Hydrocephalus in these conditions are multifactorial. A true posterior vault expansion might not prevent hydrocephalus. ETV can be used. VP shunt might worsen the venous congestion and it counters expansion. So in case you have to use VP shunt, you use a programmable one. So in this particular child, we went on to do a ETV, but he failed. He failed and presented with leak at about 11 days after surgery. And we went on to do a VP shunt for him. So if the hydrocephalus is not significant at first presentation, you proceed with posterior distraction, the extent of which would depend on the age of the presentation. And with that, you add foramen magnum decompression. The option of frontal orbital advancement will be staggered to a later date. So the posterior distraction might be occipital and suboccipital, with or without a foramen magnum decompression. So how do you choose between anterior or posterior distraction, and why posterior? Posterior prevents turocephaly and reduces the occipital flattening. It decreases the venous congestion. Probably it prevents and reduces the chance of development of hydrocephalus. It decreases the possibility of central sleep apnea. And posterior distractions, these are the advantages of posterior distraction. You have a greater increase in the intracranial volume for about at least 30% compared to anti-distraction. And distraction by itself has a better bone building and a lesser chance of relapse. You get a greater distraction when you do a distraction over standard fixation of posterior calvarium. There are some other advantages like reduced blood loss, etc., which is not commonly accepted. These are the different phases of distraction osteogenesis, which happens when a posterior distraction is done. You have an osteotomy phase, you have a latency phase, you have a distraction going on, which later goes in consolidation and remodeling in later months. So whenever you have a tight posterior fossa along with Chiari, ideally they are candidates for total calvaeolar reconstruction. You might start off with a staged manner or do it in a single step. When you do it in a staged manner, you correct the occipital flattening, release the ICP by posterior distraction at that moment, and then you defer the frontal advancement for a later date. at least one author has described doing it in single step by using a modified prone position. Logically, this would add to excess of risk during that period when the baby is so small, especially a few months. This is this particular patient where we did a foramen magnum decompression along with posterior fossa distraction. He had his shunt occlusion at the same time. So he had, as you would remember, he had a shunt earlier. We occluded the shunt at the same time, and we did a posterior fossa distraction. So those are the distractors being praised, and this Dr. Pramod would highlight later in his talk, or maybe Pramod, you can just.
Yeah. See, the distractors that we have used are not distractors. These are ideally they are termed as distractors for internal anterior calvareal distraction, but these are good enough to be used for the posterior distraction as well. Now, if you notice, there are two distractors, one on the other side. What you need to do is to first mark out the osteotomy, proposed osteotomy cuts, and then ensure that your placement needs to be parallel to each other. Both distractors need to be parallel to each other. And once you have finalized on the position, you can proceed with the osteotomy. Now remember that you don't have to advance the segment. You only need to do the osteotomy cut. So you don't need to reflect the dura too much, only at the site of the osteotomy. And then once the osteotomy is done, the distractor is placed back again into the previously determined position, and it is fixed with self-drilling screws. Now it's easier with self-drilling screws, as you know, in these cases you cannot protect the dura from inside, as you have not reflected that region. So self-drilling screws are simple to use. So you can use probably a 3 or a 4 millimeter self-drilling screw, 4 on either sides of the osteotomy. So at the end of placement of distractors, you can just the arms that you see that come out of the scalp, those arms are turned with the help of a screwdriver, which gives you in R0, it gives you about 0.3 millimeters of distraction for every complete turn. So in such small children, you don't the most common rate of distraction that is followed in other parts of the body is about 1 millimeter, but in very small kids, it might fuse, the bone might fuse faster if you don't increase the rate of distraction. So you could even consider distracting at maybe 2 millimeters a day.
Okay, those are the CT which shows after distraction. You see the gap that has developed, and the posterior calvary moving backwards. You see the shunt in place. You see the distractors in place, and the foramen magnum has been decompressed, and we have not gone in the subocciput. We have preserved the subocciput to disallow cerebellar herniation downwards.
Yeah, see, we have distracted the entire length of the distractor. This distractor can move bone up to 2 centimeters or 20 millimeters. So we have done 20 millimeters of distraction in this particular patient. So the amount of cranial expansion or the increase in the cranial space that happens is very significant, but it is not sudden, it is gradual, right, Suhas?
So that's the advantage it gives to the skin too. You do not have a stretch of, you do not have an expansion which would damage the skin by sudden expansion. That's probably very, very important in very, very small kids.
Yes.
That's the CT along with the X-ray, plain X-ray showing the calvary from behind. You have the foramen magnum decompression. I have left a small ledge of bone to disallow cerebellar herniation, which I thought it's logically possible in such like posterior fossa. And you have the transverse sinus, which has been separated, and the bone going beyond. Subocciput has been involved, but there's a ledge of bone here. That's a post-op MRI. You can see the pre-op tight posterior fossa and the immediate post-op loosened occiput. Occipital gyrus are very clearly seen compared to the pre-ops. So the problems in these kind of this kind of surgery, the posterior distraction is obviously the venous injury. There might be a very prominent emissary, especially in older children. You might have dural tears, especially the screw going in can increase the dural tear as it is distracted. And if you have a dural tear, you use the lumbar drain. You can do an ETV if there's hydrocephalus, and to prevent it, we sometimes use gel foam below the screws so that they don't pierce the dura. But it's usually tricky. There might be persistent soakage of the exit sites. There might be breakage and malfunction of the distractor rods. We have had once. There might be inadequate decompression of the foramen magnum. So this particular child had a stomy post-op due to difficulty in weaning off from ventilation. Although radiologically he had a considerable improvement, we found it difficult to wean him off from the ventilator because he continued to have apneic and breath-holding episodes. So the next question that comes up was, why did he have these apneic and breath-holding episodes? Was it because of the hydrocephalus that's persisting? You should remember that the shunt was tied. Did he have the persistent brainstem compression, or was it symptomatic maxillary retrusion that caused his apnea and breath-holding episodes? So we had the choice for us was between doing a tracheostomy for him and maxillary distraction. Pramod, would you like to comment? Would you like to comment on tracheostomy versus maxillary distraction at this stage?
Yes. See, once we had taken care of the raised ICP issues, we looked at the midface. As you saw the child in the first photograph. There is significant proptosis, which is only a relative thing. The globe is in the correct position. It is his anterior calvarium as well as the midface, not only the maxilla, the entire midface that is retrusive. So that is what gives the appearance of the proptosis. Moreover, the child had significantly labored breathing with where he was using all his accessory muscles as well. So probably a midface distraction, without a midface distraction, would give immediate relief to his breathing issues if it was stemming from the airway obstruction due to the hypoplastic midface. So we thought we will go ahead with the midface distraction. Now, in such a small child, it is not easy. The midface distraction is usually done with an external device in an older kid. But this child was very frail. I think he was about 3.7 kilos at 8 or 9 months of age, which was too small, and his calvarium was very, very thin to support any kind of external distractors. And internal distraction also was not a choice that we internal distractors we did not think about it. There was this new technique that we have been using, wherein we use a transfacial pin with minimal osteotomy. This technique has been described by Dr. Phil Pellerin. It's there in the literature. So the idea was to use pass a transfacial pin from one zygoma to the other, and then do a minimal Leaford 3 level osteotomy, not a complete osteotomy, as the child is still growing, the sutures are still little okay. So minimal osteotomy, and then distract the entire midface with a transfacial pin. So
we have used the ROSA here, the robotic surgical assistant, which is for neurosurgery, and the transfacial pins had to be passed using a ROSA because as Pramod mentioned, the bones were very, very.
Yeah, exactly. The zygoma is so hypoplastic. You have, say, about small fingernail size of area on one zygomatic bone, and on the other side as well. So essentially you have to pass from one zygomatic body of the zygoma, which is so small where you have enough bone for purchase, to the other side. So freehanding is what has been described in the literature, but then you have very shallow orbits, as you can see in the previous slide. The orbits are very shallow, and moreover this is a very small kid. The kid has all his primary teeth and the secondary, the permanent teeth, tooth buds, which are there up in his maxilla. So you have a lot of vital structures there which you don't want to hurt. So the idea was of using the robot was the ROSA, that it gives it lets you select a linear vector through which you can pass your K-wire. It is only application which we have taken from the routine applications of the ROSA. It helped us to pass the plan the trajectory of the K-wire and then execute it with precision without getting into the orbit or without injuring any of the tooth buds. So that's the way that you can see the transfacial pin is what goes from zygoma to zygoma, and then there are two rods on either sides. Those are the actual distractors. So these distractor is in the posterior. It is fixed to the temporal bone with the help of a plate and self-drilling screws, and then there are small nuts on the distractor which you turn, and when you turn the nuts, the cylinder comes forward and pushes the entire midface forward as it pushes the pin forward. So that's a CT which we had taken to ensure that our placement of the pin was correct. And in the last one on the right side, you can very well appreciate, one can very well appreciate the position of the K-wire, the position of the two cylinders on either side, and the two small pins which hold the distractor onto the calvarium in the posterior part. That's some other views. So that this is him before on the left side, the pre-op. You can see the photograph before his distraction was done, and on the right side you can appreciate there is significant support for the globe there. The proptosis has reduced, and his nose and the upper lip, if you look at the upper lip, you will be able to make out how much the midface and the maxilla has come forward, which opened up his airway immediately. That's the advantage of distraction. As you go on distracting, see, it's a mechanical obstruction. If it is a mechanical obstruction due to the hypoplastic midface, as the midface comes forward, the child immediately becomes symptomatically better, as you can see. Suhas.
Yeah, so we obviated the need of doing a tracheostomy by doing a maxillary distraction. And the next question, that as he followed up in the next few months, he continued he proceeded to have increasing head circumference. So now the question again arises: shunt, whether to proceed with the shunt or not, and if yes, what kind of shunt? So he had progressive raised head circumference, and he went on to have a programmable shunt. That's acceptable in literature. So whenever you need to do a shunt in a child with craniosynostosis, we do a programmable. Try to proceed it with the endoscopic thoraventriculostomy in spite of its high failures. So again, I would remind you of these final thoughts. The hydrocephalus is multifactorial. Posterior vault expansion may not prevent hydrocephalus, as you noticed in our case. Endoscopic ETV can be selectively used, although high chance of failure. VP shunt is possible, but it counters the expansion. That's very important. So if VP shunt has to be used, it has to be programmable so that you have a better control of the expansion of the calvarium. The next case I would like to illustrate a few more points. So this was a 9-month-old who came to us again with a full fontanel, classical occlusence with maxillary retrotion and proptosis. His coronals were involved. He had a midface retrusion. He had papillomatic presentation. So that was the boy. He had unilateral. He had bilateral proptosis, plagiocephaly, and maxillary retrusion. So that was his scan. He too had a Chiari. Not much of hydrocephalus. Notice that. So that's more of less of anterior posterior diameter. So he had one coronal was involved, and lambdoids were involved. right coronal. So you had both the lambdoids were involved, and you had this lacunae. So we went on to do it with the posterior distraction. Again, look at the decision making here. The child did not have obvious hydrocephalus at presentation, so we went on to go ahead with the posterior distraction. Again, the same technique. Again, it was the subocciput was not decompressed. Foramen magnum was decompressed. That's him post distraction. That's you see that subocciput has been preserved much more than the previous child. Again, the transverse sinus is intact at this level appropriately. And then this is post distraction. Some other view. So these are the pre-op scans. You can see the posterior calvarium, which is very tight, and look at this post-op where you get an occipital gyrus very clearly prominent, and the posterior fossa, which is very prominently open. That's him immediately after his posterior distraction. Beyond that, he went on to have his frontal cranioplasty and transfacial pin.
So that was this stage 2 where we had to address the midface. Now, if you remember in the first case, we had not addressed the calvarium in the first when we did the midface. Now, these are kids where we can include two surgeries in the same stage. We can do frontorbital advancement and cranioplasty, anterior two-third cranioplasty to address his deformed skull, which is caused by the unilateral plagiocephaly, as you can see there. And again, we can also address his midface at the same time. So what we did was we did cranioplasty and midfacial transfacial pin along with distractor placement at the same time. So that's the distractor placed, as well as frontorbital advancement and calvarial remodeling done. If you can appreciate it, on the left side, the globe is much more protruding, whereas on the right side, as a part of the as an effect of the frontorbital advancement, the eyes are in a better position, and the shape of the calvarium is also addressed. See, there was an appearance of pterycephaly there, which and the slope of the forehead also was wrong, which was also addressed at the same time. So that's him at the almost at the end of the midface distraction. He improved symptomatically. He had issues with breathing, which resolved as the distraction progressed. He also had multiple episodes of subluxation of his globe, for which he had previously undergone permanent lateral tersorrhaphies. At the end of the distraction, he also got significant support for his globe, and there were no more episodes of globe subluxation. So in effect, if you see, the functional issues include the issues stemming from raised ICP, as well as the issues stemming from midface retrusion in syndromic craniosynostosis. The midface issues are primarily related to vision, exposure keratitis, globe subluxations due to midface retrusion, as well as airway distress due to midface retrusion. All these issues were addressed with this procedure.
So as we would summarize that whenever you have a CSF diversion, the dilemma is between whether to choose between ETV and shunt, whether to use CSF diversion versus posterior decompression, and the next question would be the extent of decompression. We would illustrate some more dilemmas with another case. This was a 15-year-old who had a classical Cruzen syndrome, a female child. She had a shunt at a hospital elsewhere during her infancy. She presented to us with a severe developmental delay and difficulty in walking. That was her classical cruisans with classical midface retrusion and brachycephaly. That was her calvarium. She had a shunt from outside, as we mentioned. So that was an MRI showing the syrinx and a tight posterior fossa. And she had a shunt from outside, which was functioning. So she survived because of the shunt, but at the same time she was completely damaged, developmentally delayed, and with proptosis and the newly developed syrinx at presentation. That we decided to have a posterior fossa distraction, a posterior distraction, because her syrinx was the most important complaint when she arrived to us. So that was the calvarial cuts which were planned, and the distractors on the STL model again. And the subocciput was completely preserved. If you notice on the MDCT, you have a very prominent emissary at the level of transverse sinus. So that was one more reason why we proposed a intact subocciput. So these emissary are completely compensatory and compensatory for the old hydrocephalus. So these can be very dangerous when you have an older child who comes for such procedures. So that was the cuts that was planned. You have the emissary that is preserved, and you have the cuts going close to the shunt, but behind it.
Yeah, it's the distractors that we have used here are indigenous. They are not the Arnold distractors. It makes it cost effective, but they function almost the same way. The principles are just the same. These are more rigid, but in an older child, it's easier for them to manage.
So she went on to have a posterior calvarial distraction and a foramen magnum decompression. The subocciput was completely preserved. So in the older children, you do a posterior distraction with keeping the subocciput completely preserved, because so you need to do an angiographic study before you proceed with posterior distraction in older children, because they might have compensatory, very important compensatory veins which might run across to the transverse sinus. And at the same time, they can be managed like any other Chiari syndromes. You might do a simple, straightforward foramen magnum decompression rather than posterior calvarial distractions. So that's her posterior calvarium. After distraction, you have the occiput completely opened up. The foramen magnum was decompressed. You can see the foramen magnum decompressed, and you have a posterior calvarial distraction. Just to complete the neurosurgical implications in craniofacial dysostosis, we have encephalocele. This was a child who presented to us with this midline bulge, a classical encephalocele, and he had hypertelorism along with.
Yeah, here the one of the most difficult aspects of encephalocele that persists even after the encephalocele has been taken care of is the long nose appearance, which you can as you can see, this happens as due to the fact that the nose is pushed down by the encephalocele during the growth of the child. In this particular case, it was completely restricted to the calvarium, and it was not entering into the nasal cavity at all.
So once the encephalocele is isolated, it can be disconnected and excised, because it's usually a dysplastic gliotic tissue, and then you patch it outside with a pericranium and repair the dura completely, or primary closure, because the neck is usually very narrow.
Yeah. if we can just add here is that once you expose it and excise it, the question is how do you decrease the length of the nose? Well, one way to do it is to bring the frontal bar down. In the first photograph, that is one on your left side, you will see that the frontal bar has been brought down. Okay, so that ensures at the root of the nose, and there is a small bone graft which has been placed as well for the dorsum or augmentation of the dorsum of the nose. But this is in this particular step we are essentially recreating the nasofrontal angle at a much lower position than what the child had, and the upper part where there is a small defect, that can be bridged with the help of another small graft taken from the parietal bone. And then, as Dr. Suhas mentioned, the patching is done with the pericranium, and we proceed for closure. And this gives a reasonably good functional as well as aesthetic outcome, as you can make out from the photographs. The nose is still a little long, but you can get away with it. That's it. We'll stop. Yeah.
I'll just summarize how we go about by initial evaluation, and then Dr. Pramod will continue with the rest of the. So we start off with basic evaluation for raised ICP by simple clinical examination, and then sleep study, and depending on the problem that appears at presentation and the age of child, you proceed with management of raised ICP by using a shunt if there's a prominent hydrocephalus, endoscopic third ventriculostomy to be given preference, of course. And then you do a posterior distraction, and the rest of the management would be timed as and when required, and a later date. I think I'll just hold on for the moment, and then we'll continue with Dr. Pramod's presentation after, if there are any questions on the neurosurgical implications. Dr. Deepak.
Okay, you want to try some questions now, or?
Suhas, Dr. Suhas?
Yeah.
This is Dwarka. This is Dwarka here.
Okay, let me just ask Dr. Srinath if he has any questions, or Simon, or comments.
Dr. Suhas, can you hear me?
Yes.
Yeah, this is Dwarka from Nimhans here.
Yeah. Hi, Dwarka. Yeah, tell me.
Hi. It's a very nice presentation. Really enjoyed it. I just wanted to know what have been your outcomes. Do you have had any? What sort of distractors are these, and who makes it for you, and how much do they cost? And second thing is, have you had any infections or complications related to the distractors?
Yeah, this is Pramod here. If I can answer your question, see, you have many companies that make distractors. Now, the usual distractors that we use are from the company KLS Martin. It's a US-based company. Now they make distractors, various kinds of distractors for specific for posterior calvareal distraction. They make distractors for anterior distraction. That is internal as well as external. But if you ask specifically for the posterior calvarium, we use primarily we use the distractors by KLS Martin. It is very rarely that we use Indian distractors. Cost-wise, the foreign distractors would cost about 1 to 1.25 lakhs per distractor. That is one, but remember that you need to use two. That's just a range, and the Indian distractors would cost somewhere around 6,000, 7,000 rupees for one.
Okay.
And we haven't had any infections with the Indian distractors, not yet.
So
But
how
then
long
the only difference is that the foot plates of the Indian distractors are more difficult to contour and adapt to the bone. There are higher chances of breakage and distractor malfunction, as in, sometimes it gets stuck halfway through the distraction. So those things are potential problems that can occur with indigenous distractors.
And what about the infections? Have you had any infections? How long do you keep them?
No, we do not have any infection at all.
Not
So
yet. We haven't had any infection. See, the exit tract of the distractor arm that comes out through the scalp needs to be maintained very clean. But the patients, the parents can take care of it. They just need to wash it daily, clean it with betadine solution, and then apply some betadine ointment. You don't need to have a dressing over there once the bone heals. You might see some granulation tissue there, but you don't, if you keep it clean, that does not happen. But no infections, no, not yet.
how long do you keep them?
Suhas had initially mentioned about the steps of distraction. The first one is osteotomy. The second one is the latency period. The latency period is about 5 days to 7 days in adults, and that is for the initial callus to form. See, we are not distracting the bones, we are distracting the callus. You remember that, okay? So you have to allow let the callus form during that period. So then you start distracting the callus, and then you have the distraction period, which is according to how much you need. It is not always a fixed one. It is specific for each patient. The need of distraction for each patient might be different. So once you have completed the distraction, then you have the consolidation period. The consolidation period is when you allow the callus to completely solidify. Okay, you want it to be as strong as the adjacent bone. So the earlier people used to say you have to keep it 1.5 times the period of distraction. So if you have kept it distracted for say around 20 days, you have to the consolidation period would be around 40 days. Now that is slowly changing. The consolidation period is becoming more and more. I keep the distractors on for about 3 months, whether it is internal or external, so that the bone really becomes solid before, and remember that acts as the fixation to hold the advanced bone in position. Once you remove, if you remove it too early, there is a chance that you may the advancement that you got might relapse. So you keep it at least for 3 months. There are people who keep it for 6 months as well. That's for the anterior though.
Okay. Thanks a lot, sir. Thanks.
Very good. Simon, do you have a question or comment?
Oh, yes, please. Thank you very much for the presentation. I would like to ask if you wouldn't mind commenting briefly on genetic testing for the mutation. Is it common for parents who do not have that mutation in their family, and is it expensive?
It is expensive. We do it very commonly, and it depends on the family's inclination for getting it done, because especially if it's a first child, they would like to know what is the importance of the present child's issue on the future family expansion. It is expensive, so that sometimes becomes a hindrance for us for doing it on everybody.
I see. Thank you very much.
Very good, gentlemen. Would you rather make it a long one presentation, or do you want to divide it up in part 1, part 2?
Let me try to load. I have say about another maybe 10 minutes, few more different scenarios to show you.
Okay, do you want to continue on, or divide it up and start another presentation?
No, I will continue on.
Okay. Oh, very good. Okay, continue then.
Yeah. Open folder. Yeah. Neurosurgery.
Okay, we're not seeing the screen share yet.
Yeah, we're trying to.
Okay.
Are you seeing the screen now?
Not yet. Nope, we're seeing the line of the crew. There we go. Oh, we're seeing. Not yet. You open up what you want to open up.
Yeah, is it open now? We have opened it here.
You are screen sharing, but you're going to open something, right?
Yeah.
Okay.
Can you see this first slide one now? First slide?
Not yet. Not yet. I don't think you've opened the slideshow yet.
We are slideshow.
Or whatever you're going to open. You haven't opened it yet.
Yeah, clear?
Is that visible now?
Well, you're screen sharing a group of files. All we're seeing is a group of files. Board, prep, mat, ebooks, iPhone videos.
Yeah, but we have.
We're seeing a bunch of files. You're sharing the wrong screen, probably. Okay, you're back. Okay, you're back. Not screen sharing.
Whatever now, yeah?
Yeah, yes. Perfect.
All right, good.
Yeah.
Yes.
So we'll go like this. Yeah. Can you hear me?
Yes.
Yeah. So this was another child. We are going to just go through different. We have gone through posterior calvarial distraction and one specific type of distraction where we have shown transfacial pin, which was used for midface distraction. Now this is another child. He is again a cruise-on who had multiple cranial suture synostosis involving the both the coronals as well as part of the sagittal suture. So there is a slight appearance of an oxycephaly as well, along with severe midface retrusion. You can see there is significant proptosis. There is a change in the ocular axis. If you see on the right side, one cannot see his upper teeth at all. In the place of the upper teeth, you see his tongue. So that says that his midface is really hypoplastic, and the tongue doesn't have enough space inside the mouth where the tongue is supposed to rest in the arch of the palate. Since the maxilla is so hypoplastic, it doesn't have the tongue doesn't have space and it protrudes out. That's the appearance, a typical appearance of a craniofacial dysostosis that you see. Now you can see that there is lacunae all over the calvarium. So we proceeded with internal distractors. Now, if you on that screen, you can see two distractors, one for the frontorbital bandu, and then one distractor which is resting on the zygomatic, the body of the zygoma. The upper one is the Arnold distractor, which we had seen earlier in the previous posterior calvarial distraction. Now the one below, with the longer one, is the Marshak distractor for midface. Both of them are internal distractors. And now in him, what we have done is we have not staged the calvarial procedure and the midface procedure, but for him we have done it together. Now that's called monoblock distraction, where we move both the calvarium and the midface in as one single block. Earlier, what was practiced before the advent of distraction was monoblock advancement. Now that was a very morbid procedure with mortality rates of up to 50% in certain series. The reason being, you open up a big gap between the nasal cavity and the cranial cavity when you advance the frontal bone and the midface together. Now that was not acceptable mortality or morbidity for any kind of surgery. So what the advent of distraction did is that you only do the osteotomy, you don't advance at all. You do the osteotomy, you keep the bones back into the same position, then you fix the distractors and come out.
and you wait for about 7 days. Now 7 days is good enough time for a layer to form between the calvarium and the nasal cavity. Now, when you distract in a monoblock situation, the morbidity is very, very less. So that's the intraoperative photographs where we have taken out that bulge in the cranium. The osteotomies were done and the distractors were fixed at the same time. So mild cranioplasty was performed just to get the shape correct. And this is him at the end of distraction. You can see that the orbit has got significant amount of support. His eyes look reasonably normal now. We went through this child before, so I will skip this. That's how the ROSA planning is done. The slideshow.
Which one?
Yeah, that one slideshow there.
Yeah. This is free, no?
Yeah. Yeah. So that's the neuro robot, and what the robot does is that it helps us to pass the K-wire. In the right upper corner photograph, you can see there is a drill guide which actually is part of the robotic arm. So when we pass the K-wire through the drill guide, it allows you to maintain that same trajectory that you have planned in the on the CT scan in the computer workstation. So that's how ROSA helps, and we can do that in just one single pass. Unlike the other, if you freehand it, you might enter into the orbit and then come back, and then you may have to pass it again, or you come out through a very shallow part of the other side where you don't have any kind of support at all. So that's how it sits. That's him. This is the other child. Hello.
Yeah.
Can I continue?
Yes, hello. Yes, please.
Yes, yeah. So no, there was some disturbance in between. Now this is another child which is done separately. This is not a monoblock distraction, but we have done the calvarial remodeling and the frontorbital advancement and the distractor placement at the same time. Okay. The reason why we have not done a monoblock in this case is because he had calvarial deformity, whereas the other child, the calvarium was reasonably, even though it was retrusive, it was not deformed. So we could afford to bring it forward as a single block, whereas this child required remodeling of his calvarium to correct the shape. So that is the reason why he was, the procedure was, even though done at the same time, it was not done as a monoblock. So we corrected his calvarial shape, advanced the frontorbital region, and then fixed the transfacial pin to advance the midface. Now, what many a times we get in our scenario, in Indian scenario, we get very older kids who have undergone probably some kind of procedures which are not effective. But this is another girl who came to us. The typical features, as I had said earlier, frontal protrusion, proptosis. You cannot see the teeth in this place. You can see the tongue. So this is the external distractor that can be used. This girl again underwent fronto-orbital advancement and calvarial remodeling along with leaf-3 osteotomy and distractor placement at the same time. So we addressed the fronto-orbital retrusion and at the same time did the midface osteotomy and fixed the external distractor. Now this is like the halo frame which was used earlier by maxillofacial and neurosurgical neurosurgeons earlier. Now it has come back. So what it does is we fix that. It's not a complete halo, partial halo. We fixed onto the calvarium with the help of titanium screws, and then there are two horizontal arms to which the midface is connected with the help of stainless steel wires, and then again you have screwdrivers which, when you turn 1 millimeter a day, brings the midface forward. As you can make out from the first photograph, where the midface is significantly retrusive, the globe is proptotic, whereas in the last one on the right side, you can see that there is good support for the in the infravital region for the globe, and the midface has come forward. Now this also improved her upper airway, and the breathing became much better. So here you can see you can see her teeth now. Now in this situation, we are addressing aesthetics here. So see, essentially, when you, in all these cases, when you address the function, the aesthetics takes care of itself. That's what I would like to say. It is not a single stage procedure. You require multiple surgeries, minor surgeries. Even this girl requires ophthalmologic intervention to correct the ocular axis in the right eye. But she's much better. Once that is done, she is back to, or not back to, she is going to be normal again. The teeth are visible, her smile is much better, and she will need orthodontic treatment, of course, but that will take care of function as well as aesthetics. Now, just to complete, this is another child who had hypertelorism, significant hypertelorism, but it was there was a sign of a facial cleft, but it was not going into the cranium at all. So usual type of hypertelorism correction was performed for him. See, in these kids, you don't. There are two ways in which you can address hypertelorism. One is by facial bipartition, where you you split the face into two, and then remove the excess from the center, and then bring the two facial segments of the face to the center. But that is not mandated in children or patients where their occlusion is normal. Remember, when you split the upper face into two, that is going to completely disrupt the occlusion. So if the occlusion is correct, if the bite is correct, if the teeth are in normal position, what you do is a box osteotomy. As you can see there on the slide, the orbits are cut as is cut like a box on either side. Then the central segment, which is removed, the paramedian segments are removed. There is a specific variation where you can keep the central segment intact, and then you bring both the boxes which contain the globe to the center. Now remember that the skin is always excess. We always tend to feel that we can leave the skin alone, it will redrape and it will cover. That doesn't happen. That just doesn't happen. Whenever the skin is excess, it has to be removed. Otherwise, how much ever bony work you do inside, it will not be seen outside if you don't take out the skin. This child had a small defect in this nasal skin as well, so that had to be excised. So the excision of the skin was performed at the same time. So that's him. Now this scar will settle down very well. It's a small kid. In another 2-3 years, his scar is going to be much better. I would still say that maybe we could have, there is scope for removal of little bit more of midline skin, which would make him look a little more better, I think. That's it. I think that we'll stop there. The other hypertelorism does not come in the purview of our topic here. Any questions?
Okay, thank you very much. Thank you very much, gentlemen. Dr. Srinivas, the opening closing comments or questions? Or Simon? Great presentation. Really fantastic photos and radiographic studies. I'm sure the neurosurgical community enjoyed that. And we welcome you gentlemen back anytime to do more presentations, and we're glad that you're open to this type of platform. It's a very useful platform, and you can present just like you do at a regular conference. Did you enjoy that yourself, gentlemen, presenting?
Hello?
Yes, yes, okay. Okay, very good. We'll be sending you the link to the Hangout, which hopefully you can use in your portfolio. And someday we'll be able to get credits for watching that.
Yeah, I have a question.
Yes.
When are you going to upload this on the YouTube? Because see, some of these patients we are still trying to contact them to take their consent before it goes online. So if you can hold on to our presentation for a few more days before we, so that we can get back to you before you put them on the YouTube.
Yeah, well, yes. I'm not sure if I understood your question, but I think the link to the video will be free and be public and on YouTube. And I'm gonna send it to you. It's gonna be accessible to the public. And you'll be, of course you can use the link to do whatever you want.
Yeah, can you hold on to? Is it already online on YouTube?
Yeah. Right now we're online, but this is all being recorded.
Yeah. So if you can hold on before you put on the YouTube, we need to take
Okay. Okay. Let me just stop this presentation and then we'll chat. Okay.
Yes, sure.
Okay. Thank you very much, gentlemen.